The basics of DXA radiation safety training is a mandatory component of the operator training for the DXA in the Human Performance Lab. The overview of this particular training will go over the basics of radiation identification and terminology, basic DXA mechanics, and exposure limits. The kind of radiation that we're talking about when using the DXA stands for Dual Energy X-ray Absorptiometry. So in the name implies that X-rays are used, and X-rays occupy the ionizing radiation side of the electromagnetic spectrum from about 0.01 nanometer wavelength to about 10 nanometer wavelength. The units of radiation dose, important to understand, are the absorbed dose, which is the energy absorbed per unit mass, and the international units being the gray, abbreviated GY. It is non-tissue specific and generally used for doses greater than 1 gray. And then there's the dose equivalent, which is the absorbed dose times a weighting factor based on the tissue type. The international unit for the dose equivalent is called the sievert, and it's abbreviated SV. When the whole body is being considered, the weighting factor is 1, which makes the sievert equivalent to the gray. The fundamentals of radiation protection include time, distance, shielding, and contamination control. With a DXA, since we're using X-ray radiation, when the X-ray source is turned off, there's no more radiation in the area, so contamination control is not used. Shielding is used within the DXA system in order to block radiation from going in directions that aren't required. Distance is maintained for safety by operators and by the general public. And then time is just basically that, limiting your time in the exposed area. The basic technology of the DXA is that it emits 2 photon energies of X-rays with different attenuation properties. The X-ray source is underneath the subject who will be laying on the bench of the DXA system. There's a high energy and a low energy X-ray. The high energy is attenuated by bone only, as you can be seen in the picture to the upper right. And the low energy X-ray is attenuated by soft tissue. Of course, soft tissue is made up of all different types of densities of tissue, and the software within the DXA system can distinguish between the different types of tissue, especially fat and lean tissue, based on those attenuation profiles. DXA specific radiation safety in terms of research subject and patient, operator, and the general public will now be discussed. The radiation limits for an adult research participant per year are always as low as reasonably achievable. This is called the principle of Alara. However, we're not to exceed 30 millisieverts, okay? And in a minor is defined as someone less than 18 years of age, is half the adult dose, so it would be 15 millisieverts. And this number doesn't mean a lot right now, but in the coming slides you'll understand just really how high that is compared to the dose that they get from a DXA. So, how the operator ensures subject and patient safety? Well, first, you follow the principle of Alara. Second, you determine whether or not the IRB has approved the scan for this particular subject, and in this case that would be a research subject. Really foremost is to determine whether a doctor's authorization has been ordered for the DXA scan. In the state of North Carolina, DXA is still considered X-ray in the healing arts, and a doctor's authorization is required for all DXA scans. If the IRB has reviewed the protocol for a particular research project, then there is the assumption that a doctor's authorization has already been obtained. Otherwise, it wouldn't have passed IRB review, and IRB stands for Institutional Review Board. And the way that we determine whether or not the IRB has reviewed and approved the procedure is through an informed consent document. It would be a blank informed consent document that has the date, it's a start date and an end date that the IRB has reviewed the protocol for. So as long as that informed consent document doesn't have a date that's expired, then we're allowed to go ahead and scan that subject. And those documents for all studies that would have a component of DXA would be in the filing cabinet under the folder that says IRB reviews or informed consent. Doctor's authorization orders are needed in situations where there has been no IRB review, where scanning a subject perhaps for the cardiovascular risk reduction program in FIT, or perhaps just an individual or an athlete who's come in to be assessed for body composition, and we're doing DXA on that individual. We have blanket coverages by our physicians for some procedures. The cardiovascular risk reduction program is one, and there is an actual form under doctor's authorization folder in the filing cabinet that tells us that we have the permission to scan all folks who come through the cardiovascular risk program. We also have blanket coverage for anyone going through this operator training, because as part of operator training you have to do at least one scan, and typically operators who are going through the training will scan each other. There is then the training that you're going through now that helps ensure subject and patient safety, adherence to defined protocols. Whichever protocols are going to be used in the study or the way that you're going to use the DXA, you need to adhere to that. And no repeat scans without primary investigator authorization. So that means that when the IRB reviewed the project that's being done, for example, a project that includes a DXA scan before and after a particular intervention, then the IRB only approved 2 scans. If you scan someone and find that you screwed up the first scan and you have to do it over, then that person has already had 2 scans, and after the intervention would then be a 3rd scan. So the primary investigator has to be informed of the fact that an extra scan was done, and because they may have to report that back to the IRB. When it says no repeat scans without PI authorization, more to the point, it's if you have to repeat a scan, you need to report it to the primary investigator. Okay, so this is what's going to help put radiation dose into perspective. The estimated research subject dose from the HPL DXA is about 0.4 microsieverts. So the scan time for a whole body dose, and we usually do whole body scans, is about 4.6 minutes. They're exposed to 0.4 microsieverts of radiation. Now recall that the annual dose limit for a research subject was 30 millisieverts per year. So this is 75,000 times lower than that per year annual limit. So if you think about it in terms of the subject not doing any other research that involves radiation, we could actually scan them 75,000 times just to reach that dose limit. So that gives a pretty good cushion when you consider how much you're actually exposing the patient to. But we still want to follow the principle of ALARA and still limit as much as possible the amount of radiation anyone is exposed to. So the occupational radiation limits for an adult per year also has to follow the principle of ALARA, and that is actually protecting us as operators. We as operators of the DXA are considered non-classified radiation workers, and we're allowed to be exposed to 6 millisieverts of radiation per year. Now recall that it's 0.4 microsieverts just to the person who's laying on the bed. So we're still well below anything. Even if we were laying on top of the person who's on the scanner, we would not be getting anywhere close to 6 millisieverts in a year, even if we were the only ones scanning people in the DXA facility. Okay, so how do we ensure operator safety? We follow the principle of LARA, follow the occupational exposure guidelines, as I've just indicated, the training that you're taking now, and adherence to defined protocols. One such protocol is that the operator is typically a minimum of 3 feet from the DXA during the scan. And then annual radiation survey and protocol review, which I'll go over momentarily. How about the general public? The general public limits per year are, again, as low as reasonably achievable, so we make every effort to make sure the general public isn't exposed to any more radiation than they need to be, or it can exceed 1 millisievert. Now again, remember, the person lying on the DXA system is receiving 0.4 microsieverts. So how do we ensure general public safety? We close the door to the DXA room during the scan so that somebody doesn't accidentally walk in and possibly expose themselves needlessly. We don't allow unauthorized persons in the DXA room during the scan. Now that doesn't include, let's say, the parent of a child that you might be scanning, the spouse of someone you might be scanning, or in the case of this training, it also doesn't include any of the students who might be training at that time. Don't allow unauthorized use of the DXA room. So the room is for DXA and nothing else. So technically we shouldn't be in there doing skin folds. We shouldn't have people in there changing, especially people who aren't trained around the DXA to begin with. It could accidentally be turned on, and then you'd be needlessly exposing someone to radiation, which does not follow the principle of LARA. There are caution signs on the door to keep people from entering when a scan is occurring. Again, we adhere to the defined protocols, and there's an annual radiation survey and protocol review, which I'll go into next. So the radiation survey of the DXA and FIT is done by hanging detectors at each of the 4 walls while the DXA system is running. And what's been measured at those detectors has been less than 0.1 millirems per week. Now I've changed to an absolute absorbed dose instead of using the gray or the sievert here, because that's the unit the detectors are in. And when it says less than 0.1 millirems per week at each wall, that's because that's the highest sensitivity that the detector has. In other words, it can't detect lower than 0.1 millirem per week, and so that's what we're getting at each wall, and it's actually probably lower. Remember that there's only a 0.04 millirem absorbed dose per whole body scan, so the person who's actually laying on the bed is only receiving 0.04 millirems. So now that's not to diminish the fact that these people are being exposed to X-rays, and not to diminish the fact that we probably don't really have a full grasp of what this X-ray radiation can do to someone's body. We have a pretty good grasp of it, and we think we know how safe we're being. But that's why we want to limit exposure as much as possible, even for small doses like we're receiving from a DXA scan. So by comparison, and to help put things into perspective a little bit, astronauts, their occupational limit per mission is 250 millisieverts. Okay, that's 625,000 times greater than what they would receive if they were being scanned on our DXA. A coast-to-coast U.S. round flight trip at 35,000 feet exposes everyone on the plane to about 120 microsieverts. So that's 300 times greater than what they would receive if they were having a DXA scan. So everybody flies all the time, so they're always exposing themselves to much greater levels of radiation than anything that they're receiving from a DXA scan. Next, we'll go over some of the documentation that you need to understand as part of your training.